Welcome everybody to today's Meet the Authors webinar. What we're going to do today is talk about the ASPIRE guidelines for assisted reproductive technology, laboratory practice in low and medium resource settings. Now, these guidelines tackle one of our biggest shared challenges, delivering high quality IVF services when resources might be limited, whether it's due to budget constraints, infrastructure, or workforce. Our goal today is to move beyond the text on the page and dive into real-world strategies for implementing these standards. Now, these guidelines were developed to provide clinical recommendations to improve the standard of care in the APAC region. The guidelines represent the view of ASPIRE, which were achieved after careful consideration of the available scientific evidence at the time of preparation. So this was in 2022 to 2023. The aim of the clinical practice guidelines is to aid healthcare professionals in everyday clinical decisions about appropriate and effective care of their patients. However, adherence to these clinical practice guidelines does not guarantee a successful specific outcome, nor does it establish a standard of care. So I'm Ryan Rose, I'm your moderator for this evening. Let's get things underway. So I'm going to start by introducing our presenting author tonight. It's Dr. Haroon Latif. He's an accomplished clinical embryologist and clinical sexologist with significant contribution to the field of fertility and endocrinology. He's currently the Chief Executive of Lahore Institute in Fertility and Endocrinology, so LIFE, the Managing Director of Hamid Latif Hospital in Lahore, and the Director of the RLK Associates. He is currently the president-elect of ASPIRE as well. So he's got a presentation that we'll start off with this morning, and then we'll lead into the question and answer session.
Hello, everyone. I'm Dr. Haroon Latif. I am a clinical embryologist, and I'm also the president-elect for ASPIRE. Today, I'm going to talk about a fairly recent publication in Fertility and Reproduction, which is the scientific journal for ASPIRE. And the topic today are the ASPIRE guidelines for ART lab practice in low and medium resource settings. Obviously, it's an extensive document, so I won't be able to go through each and every aspect of it in the next 10 minutes or so. So I'll just give you an overview of this publication, followed by a detailed question and answer session. So the rationale behind this particular publication is that APAC is a very diverse region where access to ART varies significantly between various countries. So the purpose is to establish baseline standards or guidelines for ART in limited resource settings so that we can ensure quality, we can ensure safety, and we can also ensure that all practices are ethical practices. As you can see, that the gaps observed across Asia-Pacific region in quality of reproductive care due to financial, cultural, and infrastructural constraints. So access to ART varies significantly with higher availability in countries like Australia and Japan as compared to developing countries like Pakistan, Bangladesh, and Indonesia. This chart depicts, it gives you an understanding of the gap in the accessibility of ART services across the region. It depicts the total number of stimulated cycles per million population. So according to this chart from this table, the global average in 2018 was 535 cycles per million. Commonly accepted benchmark for ART access in developed countries is around 1,500 to 3,500 cycles per million. This is required to meet the needs of the population effectively. However, countries with lower numbers like Pakistan having around 18 cycles per million in 2018 and Bangladesh around 9 to 10 cycles per million indicate that there's a significant gap in ART accessibility. So the key components covered in this publication are divided into 4 main headings. Although there are a number of variables in ART, especially when it comes to the lab, however, the authors have tried to cover all the key components in this publication under these 4 headings of infrastructure, equipment, personnel or HR, and of course, quality control, quality assurance. Coming to the infrastructure, the authors focused on the infrastructure which is directly linked to the ART lab. We divided the areas into clinical procedure rooms or operating theater, embryology lab, which should ideally be adjacent to the operating theater or the clinical procedure room. Embryology lab should have a separate designated area, and then there should be other designated areas for important spaces like for specimen collection, for storage of consumables, and of course, to keep liquid nitrogen davers and to keep gas cylinders. There's a long list of essential equipment that is required to set up an ART clinic. The essential equipment list is essentially divided into recommended and optional. Understanding that the cost of equipment is a big barrier in setting up an ART clinic in limited resource countries, the authors try to limit the essential equipment as much as possible without compromising on the quality. As we know, the cost varies a lot as well depending on the brand of equipment. But of course, even in our APAC region, we have various options now available where you can find some good equipment, certified equipment at a reasonable cost as compared to conventional vendors. Staffing is a key element and contributes greatly to the success of an ART program. As they say, brick and mortar only will not make a good healthcare service provider. Important factors include good leadership, teamwork, education, and of course, the all-important skill set. A lot of our embryologists learn that on job. These tables highlight the minimum standard of IVF lab staffing required and the education and experience required at various levels of the leadership ladder for clinical embryologists. Of course, we do need to be aware that these requirements may vary according to the local regulations for practices of ART in that particular country. The quality management system is associated with processes that require a clinic to maintain a set of procedures, policies, and rules that are essential to support the functioning of these processes, and also to ensure confidence that all the processes are being executed as intended. So QMS is an integral part of an ART clinic and is extremely important, a very important pillar to run a successful program. Some of the core components of the QMS include, of course, documentation and maintenance, regular audits of the clinic, both internal and external, running a key performance KPI-based clinic, basically KPI-driven clinic. Then, of course, witnessing and traceability is of utmost importance. Then there's incident reporting, safety and infection control, and preparedness for disaster. So these are the main core components for quality management system, quality control, and quality accreditation. Maintenance and documentation. As we all know that there are so many variables that I just mentioned that are linked with an ART program, and one has to cover all of these variables properly. I know that in limited resource settings, equipment is one of the main pillars of an ART clinic. However, it is also the largest barrier in setting up a clinic in limited resource settings due to its high cost. However, of course, to set up a proper clinic, we can't cut corners as far as this equipment is concerned. And not only buying the equipment, regular calibration of the equipment is also extremely, extremely important, especially those equipment that need to be regularly maintained, such as the incubators, the micromanipulators, laminar flow hoods, and other essential equipment. Another important part is that SOPs of regular monitoring by the embryologist is also highly recommended. Another essential aspect is proper and correct documentation, including worksheets and logbooks. As I mentioned earlier, QMS is extremely important, and one of the most integral parts are the traceability and witnessing. Witnessing and traceability is arguably the most critical aspect of an ART clinic, ensuring right patient, right procedure to avoid any mistaken identity. Of course, there has to be a robust incident reporting systems to log and address errors or adverse events so that to minimize reoccurrence. Obviously, we don't want to blame anyone. The concept is of blameless inquiries just to minimize reoccurrence. And of course, then there are certain protective measures that are also really needed. Safety and infection control, personal protection equipment for the personnel who are working, including gloves and overalls. Then there are universal precautions when we're handling biological materials such as the gametes. Of course, regular viral screening of the patients and of the staff also, and reducing the risk of cross contamination, whether it's in cryogenic storage or somewhere else. We have to be very vigilant about these things. The key objectives to be prepared for any sort of disaster is to prioritize safety of our personnel and our patients, to protect cryopreserved materials, gametes that are there in storage for a longest period of time, to secure important records and equipment that is necessary for the functioning of the clinic. And of course, for risk management, ART units must prepare for natural disasters, power outages, which are very common in limited resource settings. You have to have a backup generator, and not only a backup generator, you have to have a backup UPS system also, so that there is uninterrupted power supply. And of course, then there has to be agreements for alternate storage option for cryopreserved samples in case of a disaster, which can be done with collaboration with other ART clinics. And like any other healthcare unit or building, there has to be an emergency evacuation plan and regular safety drills. The key aspect for a good ART clinic is to make sure that all practices are done ethically. This is extremely important to ensure quality control, to ensure quality maintenance, to ensure identity, traceability, witnessing. There's so many aspects, so many variables to it. So ethical practices are extremely important. When we are counseling the patient, we should be providing the patients with clear information about the cost of the treatment, the potential outcome, the percentage of successes, the risks or the potential side effects of the procedures. We have to be extremely transparent. And of course, there has to have consent forms that must cover all the aspects of the procedures that are being performed. There's so much innovation, emerging technology that is coming up in the space of ART. Of course, AI has taken up a lot of space now. A lot of procedures are AI-based now, and we are heading in that direction. Of course, we can use all these emerging innovations, this new technology, to even reduce the cost of the treatments that we're giving. We can run treatment programs in batches, and there are various other aspects that we can implement so that the cost is controlled and we can provide these services to our patients in limited resources setting. The expected outcome is to improve success rates of ART procedures across the APEC region, enhance patient satisfaction and trust in the ART services, and overall advancement in reproductive healthcare in the region. So the target is to bridge the gap in global access to high quality reproductive care. Thank you so much.
So thank you very much for that, Haroon. So what I'll do now is I'll introduce the panelists that we have for tonight. So again, my name is Dr. Ryan Rose. I'm currently a scientific director in the Monash IVF group. I manage the labs across Queensland, ACT, regional Australia, and also Malaysia. With me today, I have Professor Arthur Chang. He's a professor of OBGYN at the University of Texas Health Science and Center in San Antonio, Texas. He's the director of clinical ART laboratories in UT Health Reproductive Health and Fertility Center at the US DoD's Brooke Army Medical Center. With us, we have Dr. Keshav Malhotra. He holds a master's degree in clinical embryology from Monash University in Australia, and he is one of the few ASHRA certified clinical embryologists in India. He's the lab director of Rainbow IVF and now the director of Malhotra Embryology Training Academy. Joining us as well is Dr. Dean Morbeck. He's the Chief Scientific Officer for Genea Fertility based in Sydney. He's also an adjunct associate professor for obstetrics and gynecology at Monash University, Melbourne, and serves as the secretary for Alpha Scientists in Reproductive Medicine. So the other thing that I'd like you to do today is, as we're talking through and having a discussion about this paper, feel free to drop all your questions into the Q&A at the bottom there. Just click the button and sign your questions up, and we'll be able to have a good discussion throughout today or this evening, depending where you are. So I'll get the panelists to turn on their cameras, and so you can see all our faces, so we're not just names on a black blank screen. Thank you very much. So I think I'll kick us off by talking about the first question. So I really want to begin by talking about the tensions between global best practice in ART, so what are described in these guidelines, and then the realities of limited budgets, inconsistent power supplies, and a shortage of trained professionals. So how do you, the panelists, and Haroon, propose to that other clinics reconcile these ideal guidelines with the practical constraints that we actually face daily, especially when we're talking about smaller or remote locations? Would anybody like to start?
Thank you,
Haroon.
Ryan. Yeah, thank you. Look, the rationale behind an excellent question. In fact, we can have a 1-hour discussion on this question only, because this is the most important point. The rationale behind, as the panelists know, behind this publication was exactly this, because coming from a very diverse region, that is our APAC region, most of the guidelines that have come out in recent years and even before that are either from North America or from Europe, mostly. So the reference point for a lot of these clinics who are located in these developing countries or specialists who are planning to open up a new clinic, as you would understand that a lot of these developing countries, all these clinics are mostly private entities. So these are individual doctors who are in the field and they plan to open up these clinics. So the reference points they would only get are from these, for instance, ASHRAE or ASRM guidelines or other guidelines that are from the developed countries. And that was the rationale behind it, that we need to have a document that provides a certain insight of all the challenges that we have in these developing countries and what kind of competence levels and benchmarks we need to create for this part of the world where the target is not that hard, so that it becomes a great barrier and people don't want to get into that field or don't have the resources or the skill set to get into that. So, of course, it's a living document as we realize it. A lot of work is still needed as far as this document and going forward is concerned. And we plan to keep on revising it, updating it, and getting all the input from the key opinion leaders in the region so that we can address all these major barriers and assist people who are either already in the practice of ART or are planning to come, because to cover that huge gap of the number of cycles that are being done, my country, Pakistan, has 250 million people, and total number of cycles are less than 10,000. in the country right now. So there's a huge gap, and many other examples in the region like that. And of course, we can talk about all the barriers that are there, but this is also one of the main barriers of not having enough knowledge or reference points to get into the field.
Okay. So for you, Haroon, and the other panelists here, can you give any good examples of a clinic or an experience that any of you have had where you've had a clinic that is in one of these low or medium resource settings? And have you give us an example of how this clinic has struck that balance really well? So they've had these limited resources, but then they've been able to give excellent care, and whether or not there was anything that was really specific about what they did differently.
So, Ryan, I'll give you an example of my own clinic where I'm working right now. And this particular challenge that we've addressed is through a hub and spoke model, as you call it, basically.
Yeah.
So, of course, we have one facility that provides everything under one roof, from basic infertility workup to, all sorts of ART treatments and PGT and all of that, right? However, that facility is just located in one main city. Then we have these spoke clinics all across the smaller cities or smaller towns, who some of these clinics just do the initial workup. Some of these clinics go up to as high as IUI, and then they refer the patients when IVF ICSI or related treatments are needed. So that really helped us in actually, we do run courses and everything so that the skill set of the people working in these smaller cities improve. And then we bring them up to the par, and then they set up their own setups. They have an affiliation with the main clinic. And of course, with time, some of these clinics do end up doing ART, IVF, and ICSI themselves as well eventually. But it's a good stepping stone, and it's a very smooth process. And like this, we've been able to control quality to a great extent as well.
Yeah, I think that that wheel and spoke model that you're talking about is really important when you have such just a vast geographical distance between different clinics. And that's the case that happens in Australia, right? So I'm the regional lab manager or the regional scientific director. And so what we actually do is we do exactly the same thing. We have these centralized clinics that are in major capital cities. And then all of the resources, all of the equipment, and all of the people travel out to these remote locations so that we can actually set up in an empty shell, provide the IVF service to these regional areas that otherwise wouldn't be able to have access to them. And then we pack it up and we send it all back to one of the main clinics. And this is where we house all of our biological material as well. So all the embryos, sperm, and oocytes all come back to these central facilities. So I think that's an excellent way to try to tackle like the lower medium resource settings as well, just by having centralized database, centralized places where we can ship everything out from, whether that be experience equipment or basically embryos. What about the rest of the panelists? Do you have any other good suggestions or any examples where you've seen this sort of stuff work really well?
I think in India also it's pretty much similar. Like I'll give you an example for our clinics. We also schedule cases for our remote clinics. It's somewhat different because they have their own laboratories, they have their own storage setups, but they don't have the personnel or the trained manpower required to operate or to do the cases itself. So a team would travel, do the cases, which would be pooled together or a batch sort of a scenario, and then come back once the transfers are done, and then we keep following up. As an embryologist who's managing these laboratories, having a look at these guidelines can actually help me tell them that okay, these are the minimum standards that you would want to have in your laboratories to ensure like proper results or proper QC for the unit itself and not compromising patient safety and basically again outcomes of the patient. So um, it's a good reference document for such units.
Okay. Good job while you're there. First
Yeah.
off, anybody has questions, make sure to pop them in the Q&A box. I have a question for you on that. So Ryan was just talking about taking the gametes back. So it sounds like, Ryan, you don't have cryo storage in those facilities. Granted, they're probably empty while you're away. I think that's different in India. How are you solving the monitoring? Because that would seem to be one of the more risky things that, I would be concerned about without having, that full-time staff there.
So we also now have the Indian ART bill or the law that governs us, which actually tells each and every clinic to hire one gynecologist, one embryologist, and like all the support staff that's required. So the main duty of managing the clinic or the cryo storage ultimately falls upon the center in charge and the embryologist who's already working in the clinic. What's problematic here is that we still have clinics who would have embryologists but would require a senior embryologist to travel to do procedures like ICSI, to do procedures like biopsy, and that support is then offered by bigger clinics to such smaller units. But the main liability of the clinic is on the center in charge itself.
And so they have
And
someone that knows what to do with tanks. Yeah.
yeah.
And also, I can follow up a little bit on the transporting the gametes and embryos. I think it's very critical to document the transportation time, like in and out. And also, if we can run the comparison, like between those cases and all those like local cases to see if there's any difference in the success rate. Because I have seen like a lab, I have a supervised lab doing that as well. So make sure that they are comparable to those like performed locally. And also for Ryan's question, I think a lot of small labs, or we call the low resource setting labs, I've seen in the United States and also the Asia Pacific areas. I think those who are doing really good jobs are those who actually pay attention to the basics though. Because there's often this myth that the latest technology can solve and improve your outcomes, which might not necessarily true in the low like a resource setting. If you have a limited resource, maybe because there's a peer pressure or marketing pressure to buy the time-lapse machine because everybody else have one, but maybe find the pain points like how to improve the fertilization rate first, like blood cell cyst rate first, before you spend tons of money to buy the latest equipment.
Good answers. Well, I think that sort of leads us into the next part where we're talking about the experience of the embryologists, and especially in India, traveling from other locations to go to these low settings or lower medium resource settings where they don't have that experience. So when we're talking about these kind of clinics, how do you guys, plan staffing levels to maintain safety and also quality outcomes without overextending yourselves in the clinic financially, and also stopping burnout of the embryologists that you have working for you? Because especially when you're doing these satellite setups, or if you're traveling to these locations that are batched, in order to save money, you generally have to send a least amount of embryologists possible, and you need to have them stay there for a long period of time. So how do you guys balance this in your own clinics?
I think that's a very nice question, Ryan. If I give you my perspective, I was early on following the ASRM guidelines for staffing. Um, Based on those, we actually did a consensus in India itself, and we came up with safe and ethical practices for ART clinics in India, and developed sort of a staffing mechanism for Indian embryologists, because then the problem that was being faced in our country was that there was an acute shortage of embryologists, and we really needed to maximize how embryologists were being utilized because there were lots of clinics, but there weren't any qualified embryologists handling them. But the scenario is completely flipped now because since then and since the inception of the law, there are multiple universities that are now offering embryology courses, and there are multiple embryologists who are coming into the country every year. But again, the challenge that we still face is that most of the curriculum of these universities, or whatever's taught to these embryologists, is not sufficient for us to actually hire them and keep them in. um, I wouldn't say an embryologist role. I will still say that they would be trainees with us for a couple of years um, before they can actually start taking up cases. So there has been a big evolution amongst practices in the country itself. When we sat down with Aspire to develop the staffing system, I think we took a point-based approach, and this factored in ICSI cases, it factored in biopsy cases, cryopreservation, and then gave it a point system, which is slightly different from the other guidelines that are there, but it does help in basically chalking out, or basically deciphering the amount of load that would be there on each embryologist, and then can guide clinics better um, as far as hiring is concerned. And this is important because we don't want embryologists to face burnout. We don't want so much load to be put on them that they can't handle cases. But we also don't want clinics to overhire uh, as such, because the setting is still a medium to low resource setting. So it's a interesting approach that the society has taken.
Yeah, and when you have that kind of atmosphere and environment where you have all of these embryologists working way too much, that's when you end up becoming more error prone. It's when you start having increasing risk. You have poorer quality results because they're just not performing at their optimal level. And that's the last thing we want for all our fellow embryologists and colleagues as we're moving forward. So I do want to encourage everybody still. We got lots of attendees on here. Please pop in your questions there, but we'll continue with the questions going forward. So Haroon, how is it in Pakistan when you're talking about balancing levels of embryology?
So just to follow up on what Keshav was saying, Ryan, the thing is, I see the workload as a double-edged sword. Why I say that? Because in my country, for instance, and many other in the region as well, the government regulations still allow medical technicians, like you don't need a proper embryology degree to work as an embryologist still. So a lot of embryologists or andrologists, for that matter, get into the system without any prior experience. They could have a simple bachelor's degree in one of the fields, nothing to do with embryology as such, but they get associated with one of the ART clinics and then start their journey as an embryologist over there with no certification, nothing like that. Of course, this is changing, and some regulations are coming in for us, but still, large percentage of the HR that is working are still in that category. So when they come into a busy clinic, of course, the good ones tend to learn the skill set very quickly.
Yeah.
And that, of course, helps. If that helps the clinic itself by sharing the workload, and of course improves the skill set of that particular person. The only thing is that when you have to travel, then you have to have a senior experienced person to go and actually run the batch over there, because batches are tricky, as we all know that. If something unfortunately goes wrong, then the whole batch can be compromised, and we really don't want that. So of course, for that particular thing, you need staffing that is experienced and that they're used to managing these batches. So this is how basically over here we manage that. And of course, we have a lot of young technicians who are wanting to come in the field. And hence, locally, what we've done over here is that we do run certification programs for embryologists and also clinicians to a certain extent. But those certification programs are extremely popular. It's essentially a mock lab where they come and they get the skill set to start working in the lab. And of course, that's an ongoing process. Some of the people who are already working in an ART clinic do come and do these courses to upgrade the skill set and everything. So, like Keshav said, now even in Pakistan, some of these universities are coming up with these courses, diplomas, certification programs, and even master's level. But the influx for us is still not there. Maybe in the next couple of years, we'll have more HR and more staffing. One thing good for us is the cost of HR is still pretty low. So although experienced people are expensive, but these entry-level people or early to mid-level people are not too expensive. So even in a limited resource setting, you can manage to keep reasonable staff to cover your workload.
No worries. So it looks like Dane's got a question.
Yeah, I just want to follow up on that. I mean, when I first started out, or partway in my career now, a long time ago, I was doing offsite lab directing in the US, where we batched similarly. So Arthur's done this. And one of the challenges to that point, and also Keshav is asking, how many cycles do you need to be able to actually train someone? And how do you do it? You know, it's like impossible practically to do it when you're batching and it's full on and you go in with just the right amount of staff to do what you need to do. So how are you guys solving training? Because we already know it takes at least a year to train when you're a busy enough clinic to give people work routinely. It takes at least a year. How do you do it when you have fewer cycles? And do you have a chain where you can go to the main one and learn? Does that happen for you, Haroon, with your group?
So it's very difficult to exactly, benchmark that how many cycles a person actually requires, because it varies from person to person a lot. I remember when I came to Monash for my master's, I could never get the osmolality right. I couldn't pull the pipettes properly. I was just failing in it for months and months, right? I just couldn't do it, the mechanical part. Now I feel with all the technology and, the available, anything related to ART, so it has become easier to get that skill set in a shorter period of time and build up on that.
Yeah. Arthur?
Yes. So I would like to follow up on that. So I think a lot of people like several of us here, we are kind of more like old-fashioned. We learn those embryology when we were in graduate school or like medical school or those things. But nowadays, because of shortage of the staffing, we require those younger, like a fresh, like a college graduate, they learn fast. And so I want to point out two really good approaches. The first is we're doing some marketing here for our Aspire certification course. So we have this online certification course, and we are going to have our first exam this May at the Aspire annual meeting in Singapore. So I will encourage everybody, like especially junior embryologists, to register for the course and take the exam. I think that will build up a very solid knowledge. And the second is going to the training centers. For example, like Dr. Malhotra, he runs very successful training program, and all those you can help out especially small clinics. You don't have a senior embryologist to have a time to train your junior ones. And this model has been very popular in the United States and Europe as well.
Awesome. Keshav?
Yeah, I just wanted to add like my experience with the two guidelines that I was a part of. Like Dean, you were asking me whether there is a proposed training plan or structure in our country. So with ISAR, under the guidelines, we actually did develop a training structure which basically highlights the number of cases that an embryologist has to observe, then also perform under supervision before they are allowed to work independently, and also talks about the number of cases post which they can start instructing beginners. So and it's different for, let's say, semen analysis, oocyte retrieval, biopsy, embryo transfer, etc. And with Aspire, I think what we've done is it's, if I remember correctly, it's 1 year of documented experience and 10 cycles each independently performed technique. So let's say 10 ICSIs if they performed independently, or 10 biopsies if they performed independently with successful outcomes, they can start or they can be signed off for the procedure. So that's what we've kept as a minimum standard here. In the
Yeah.
Indian guidelines, it's a little different.
Yeah, no, it'd be interesting to see that. That sounds quite, unique, and it'd be nice to see that spelled out. And I guess my point is more of just how difficult it is to do that when you're either a small clinic, you don't have that many cycles, how long it takes to get someone
Really,
trained, and whether you
it,
can send them to one of the more busy clinics if we have that option.
yeah, it really is, and that's where Arthur highlights where you send them to these different training units or training clinics or bigger clinics. They get their experience, and yeah, they can join the other clinic then.
Just to add on to that, I think it works really well for us as well, because, like I mentioned earlier, that a lot of these entry-level embryologists are already working or linked with one of the clinics. So for them to go and spend like a week, 2 weeks, learn a particular skill set, come back and then work on it, and then do the same after a few months, that works really well, and the clinic also supports them.
Cool. It sounds like these individual training centers are really valuable in these kind of settings that we've been discussing. So it'll be good to see how they are actioned across, among the embryologists that are online or the other clinics. So very interesting. Keshav.
Honestly, there's no other way for low resource or medium resource countries to function, because the job that has to be done in the university is something that we have to now do in these training centers. So I think through these guidelines, we can actually highlight even to universities that at least this is the amount of experience that we as clinic directors expect newer embryologists who are coming into the workforce to have in order for them to get jobs like from the get-go.
I think maybe we should start petitioning these universities to have a practical component that is actually hands-on skills. Because without those hands-on skills, the background information and the theory behind it becomes sort of useless if you then have to send them off to one of these training centers as well. So maybe that's the way that we should start heading. All right, so maybe we'll move towards talking about the evolving role of technology. So at the moment, we have technology that's advancing quite rapidly. Now we have time-lapse incubators, we have digital witnessing or electronic witnessing, even going back to more basic technology like telehealth. So the question that we now need to start thinking about is how we can adopt these tools in a feasible and also cost-effective manner. So which technological innovations did the panel see as the most game-changing for these low and medium resource labs? And what kind of pitfalls do you see or do you need to watch out for implementing some of these technologies?
Yeah, I think, back to, I think Arthur said it already about, the very simple approach. Actually, just the basics of doing traditional IVF, having a good generator and power backup. So like more technology around the safety of what's being done. using benchtop incubators, not time lapse necessarily, benchtops that are stable. That was a big game changer when that came out, when the equipment came out in the late 90s, that like completely changed how we cultured. They still needed to and are still needing better safety measures, some of them, in terms of whether or not CO2 is flowing or mixed the tri-gas. But I'd say for me, technology is all about a safe progression of those gametes and embryos. And so it's not high-tech AI stuff so much, it's more about really good systems for having a really good quality system.
Any other panelists have a suggestion? Or better yet, do you have any like low or mid-tech solutions that you found particularly useful in any of your clinics?
Oh, actually, one of the technology I found very useful is the mini CASA system. So in the United States, because we have a different like a CLIA requirement, so that did the wave testing, so you don't need the embryologist to do the manual semeiosis. I think it varies in different countries, especially Asia Pacific. However, you can save a lot of time and staffing efforts by going to this like a mini CASA system. There are at least I believe one or two out there, and some of them are very popular nowadays, getting more popular.
One of the low mid-tech solutions that I found particularly useful in just our labs, it was mainly from like a safety perspective when we're talking about access to laboratories. So because we have all of this equipment and we have, liquid nitrogen being delivered, all of that, you have so many people walking in and out your clinic, and sometimes you don't know who's there or when they should be there. So one of the low-tech solutions that we had was just basically a phone that you checked into, and then it pinged everybody that was on site so that they knows that the person that is walking around is meant to be there. Because the last thing we want is somebody to walk in off the street and just have access to any of our material. So that was like a really low-tech solution for us. Like it was basically a WhatsApp group, where as soon as one person arrived, it pinged everybody in the clinic. And so we knew that there was a contractor around. It wasn't just a random stranger. So in the event we saw a random person or somebody was in a location that they shouldn't be, well, nobody had a ping. So then that's when we could start asking who they were. 9 times out of 10, they just never have registered on the keypad, but that's beside the point. Okay, so Haroon?
Yeah, so regarding what Arthur was just saying, I think for us, this CASA systems also work really well, not only in the main IVF clinics, but in the periphery in smaller cities as well. Getting a proper embryology report, semen analysis report is still a challenge. At times, what reporting you get from these smaller limited resource settings are totally off the chart. So, and to make a proper informed decision, obviously, it is a very integral part. And we have deployed these systems in some of these clinics, and they've really helped in quality control and quality assurance as far as embryology is concerned. Secondly, of course, there's so much technology coming up all the time, and convenience to embryologists and all of it is there, but everything comes with great cost as of now. Maybe in future, the prices would be competitive, but what I tell my peers over here in developing countries is that until and unless that technology would drastically improve your outcome, don't adopt it. Like for instance, a good example is time-lapse imaging, right? We still don't have enough data to say that it's going to transform our results. Correct me if I'm wrong. So, and it's a very, very, very expensive technology. So that's why I'm very cautious when getting into or buying new technology until unless there's a huge impact on the outcome.
I think that is very well said, Haroon. I think all of us would probably agree with you on that on the panel. The only thing I would say for time lapse, the only thing it has a huge success and a positive nature on is patient engagement and their emotional engagement in the actual cycle. And being able to transfer information across to them that's visual and that they can see definitely transforms their engagement. Does it make better embryos? I mean, the jury's still out on that. Arthur.
So actually, I want to mention one pretty much the lowest technology way you can help the lab is to reduce the paperwork and simplify the workflow. Because nowadays a lot of embryologists, they have to do a lot of things outside lab, or they fill out the paperwork and doing those consultation. And if you can look into your like a workload and make a checklist and reduce those unnecessary or something you can just delegate to a lab assistant or somebody else outside lab to do, then give the embryologist more time to work on the truly like embryology core work. And that can actually help especially low setting labs to increase their volume.
Yeah, so patient management systems and also hiring like these lab administrators to assist the embryologist. I think that's also a great idea. Keshav.
Yeah, I'll just get back to the time lapse debate or question here. I think an important aspect that we need to think about when we're differentiating these high resource countries with medium and low resource countries is the kind of education and the kind of awareness patients have. Now, for countries like Australia, Japan, Singapore, etc., you would expect patients to do their research, to know about all of this stuff, and then to have an effective communication with you with regards to such a technology. But in India or even in Pakistan, if you go to the rural areas or even in Bangladesh, uh, they would just get more scared if you start telling them about so and so technology, showing them pictures, etc., etc. So it's not just how effective the technology is within the laboratory itself, but also how the patient population actually perceives it within that region that we would probably want to think about um, in such settings.
Amazing comment, Keshav. And that's, yeah, coming from Australia, we don't have that sort of, I think I was talking before about the medical literacy difference, and especially with like different cultures and different awarenesses. That's something that I don't have a lot of experience with. So thank you very much for commenting on that as well. It's always a really interesting factor because you don't know the patient's experience, right? You don't know the situation, you don't know where they've come from. So it's really about rather than predicting what you think their outcome is going to be, is going on that journey with them. So yeah, thank you very much for that comment. So we've only got about 5 to 7 minutes left, and I can still see that there's no open questions answered from all the attendees here today. So what I'll do is I'll just finish it up on one final comment, and I'll get each of you to comment on it as well. So we're talking about continuous quality improvement on a shoestring, right? So let's think about long-term evolution of a clinic's quality. So even with minimal resources, labs can improve their efficiency and also their outcomes over time. So what strategies or tools, whether it be monthly audits or peer reviews, can the smaller clinics or these low and medium resource clinics move towards to hit these guidelines that are pitched in the Aspire? Who'd like to go first?
I can start. Yeah.
Go
So
for it.
I think one big aspect of these guidelines was benchmarking, and that's something that is really important for medium and low resource clinics. Now, what we've tried to do with these guidelines is that obviously we have different consensus statements that are available to us, which talk about all the different rates that need to be documented. But looking at the manpower that's generally present in such clinics, all of that paperwork might not be like doable for such a unit. So what we've tried to highlight is at least minimum uh, like set of parameters that such clinics would need to document. So we've reduced it to a list of maybe 7 or 8 in order for them to at least track their outcomes and then compare it with the guidelines. We've not really tweaked on the outcomes or the benchmarks that already exist, like the ASHRAE like benchmarks, but we only try to reduce the list so that all of these clinics can actually start documenting and at least compare how they stand with the rest of the world.
Awesome. Thank you, Kashav. So we've got benchmarks and being able to apply your own clinic success to those benchmarks. So how do we get to those benchmarks if you're not currently hitting them? Dean, Arthur, or Haroon?
Yeah, so one challenge that we face in the region is that, of course, the regulatory authorities do not require the clinics to send in their results. So a lot of times, most of these clinics are working in their own silos in isolation because they're trying to, they don't want to share the information with their competitors. So that creates a lot of problem when it comes to quality control and quality assurance, because as we all know, that not all clinics are at the same level, right? So over here, what I've been trying to do is encouraging all the clinics to come together and use each other's strengths and address any weaknesses that you have. For instance, get an external auditor to come and audit for you at a very economical price. If you're getting someone from, for instance, Artec, it'll be very expensive, So someone local over here, sharing the information, what QMS measures that you're taking that could help other clinics as well. So just sharing information with each other so that we can get to those benchmarks that Keshav was talking about, identifying those weaker links and addressing them can really help each other. And this is what I've been trying to encourage over here in Pakistan.
Yeah, I
Cool.
think
Thank you.
I'd echo that. One of the things I've seen all across the world is the collegiality and willingness to work together amongst embryologists and embryologists. And the problem, of course, is you need leaders like yourself, Haroon, to make that place safe so that people can talk and share and feel okay and learn from each other. So I think, regional workshops are really good in that regard, when you have, respected, trusted leaders that can help facilitate those discussions, because otherwise they are silos and they won't break down.
So in the last few minutes, it looks like we've had a question come in right at the end. So from Shaman Kai, is the cost of a cycle a high proportion of the patient's income in these medium and low resource areas?
Yeah, it really is. I'm sure Haroon also will have instances of patients walking up to him and saying that they've sold this land, or they've sold their houses or mortgaged their properties in order to come and have an attempt to have a child. I think the bigger challenge here is that the societal need uh, to have a child and the taboo that's still associated with not having children in such regions is so much that patients are just willing to do whatever they can in order to afford a cycle. There's hardly any support from insurance or like subsidies from the government. And again, I think these are challenges that uh, we are all working towards. I'm sure each leader in each of these low resource countries is talking to their respective policymakers to get insurance for such patients so that they can afford these cycles and like not have to face that burden.
Just to put things in perspective, I've had patients who've sold their farm animals also to get the treatment done. Cost of one IVF cycle over here is between 4,000 to 5,000 USD. That includes drugs and everything, a complete cycle, right? If you look at it, it's very cheap as compared to the rest of the world, but it's extremely expensive as far as these developing countries are concerned, where about 30% of the population probably is earning less than $5 a day or something like that, you know. So paying for a $3,000-4,000 cycle is extremely, and that is the biggest barrier that we have. What we do in our clinic, it's a private clinic, but we actually run these discounted batches for those patients who are unable to afford it. We're a Muslim country, so we do like a batch in Ramadan, in a way, you know, helping the patients out, and so on and so forth. There are different times of the years that we tend to control or decrease the cost, talk to the vendors, and, you know, all of that. And even the pharma is there to help us at times and outfit. But yeah, that's the biggest challenge that we have.
So I think that also raised the question about how the lab should apply all those add-ons, you know, which will increase the cost, especially in those like a low resource setting and also low income countries. So I think that could be another like a whole hour of debate on those add-ons, which one actually works, which one is the most cost effective. Yeah.
Cool. Well, thank you very much, everybody. As we've hit the end of the session, we've run out of time. We've also covered a lot of ground today. So I hope that everybody that has attended today has found this discussion really helpful. I know I've thoroughly enjoyed it, and I just want to thank, you know, Dean, Arthur, Haroon, and Keshav as well. You know, special thanks to everybody and the question that came through as well. So if you haven't already, just remember to download those guidelines and just have it on hand, and you can always refer to it as well.